We're back today for another episode. My name is David Roach.
The government's open, David. The government is open.
Yeah, thank God. And everything's going swimmingly up there. Looking forward to seeing these Epstein files.
And I'm Jake, not in the Epstein files, and I'm an infectious disease doctor.
It is unfortunate that our podcast is policy oriented because there's so many juicy things to talk about on the news these days. But I think we've got to maintain our area of speciality and professional tone.
We're very professional. And
What are we talking about today, Jake? What's the thrilling adventure on today's podcast?
we have something that everybody is going to love, and this is going to go viral this episode. And we're talking about the 3 craziest things about Medicaid and Medicare that you didn't know about.
One thing about this episode is I definitely think it's going to be dry as a bone.
David, do you personally identify with Medicare Part A or Part B?
Jake, I'm more of a donut hole guy. So,
Part D.
Part D,
Part
I'm a Part D
D.
guy.
Yeah.
D for David. Here in Boston, they're called Munchkins. So I'm more of a Medicare Part Munchkin guy. The interesting thing about it is this is something that actually comes up for a lot of people in their lives, usually as they get older. I know all of our listeners are in the 18 to 24 age range, but for those of you who are 65 and older, I think this is particularly relevant.
What's really interesting about the 3 things we're going to talk about is that us as clinicians, even policymaker, our older relatives, our younger relatives, I'm sure none of these people have heard of these 3 things, to be honest. And you get to this point in your life when some of these aspects of the healthcare system we live in may come to impact you or someone you love. And I think being prepared for that is really important.
Yeah, it's a real slap in the face for patients when they go through this and all of a sudden they're like, what? I have to do what? How? That's a thing? Like, that doesn't make any sense. It really is a little bit discombobulating to understand what's in front of you as you age and get into these care programs. So, with no further ado, Jake, what is number 1?
Number 1 is what is called the Medicare Spend Down Program, which comes down to the fact that Medicare does not pay for any long-term care. And David, what is long-term care in this setting?
Yeah, long-term custodial care. Patients who, for whatever reason, are not able to live independently. There are millions of reasons that exists. So they're not able to live independently as they age, which honestly happens to most people if they're lucky enough to get old. They eventually have a hard time taking care of themselves, and they need to go somewhere where the people are actually taking care of them for all day, every day. And that's different than like a skilled nursing facility where they have really intense medical needs. It's just somewhere that provides this long-term custodial care. But importantly, it's not something like an assisted living facility or a retirement home where residents have independence. They have greater care needs. They need that custodial care, it's called.
Just dry as a bone, as David said, just so boring.
I mean, it is. This is boring stuff. The challenge is, as people get old, things get boring, Famously, nobody should get old, but unfortunately, we all do if we're lucky enough to.
So what this looks like is you've been working your entire life. You've built up these assets. Say you own your home. You might have the newest meme coin or the newest stock that you have, and you get sick. And
Well, you have
need
savings account,
long-term
and you have
care.
a savings account with your money that you're hoping to give to your kids, offspring, grandkids, whatever, your local church, whatever it may be, any of your assets that you have in the bank.
So practically, you worked your entire life, you have savings, you're planning to pass that money down to your local church, to some of your grandkids who want to go to college. However, you now need long-term care. So what does that look like? So for the government to pay for any of this long-term custodial care, they have both income and asset level requirements.
And just to clarify, Jake, so this is for people who have Medicare. So Medicare does not cover that long-term care. And so in order to get that long-term custodial care, you have to go into Medicaid. Medicaid is for folks who live below the poverty line generally.
And if you have over a certain amount of assets, the government won't pay for that long-term care. So you have to spend down all of your assets. And what that means practically is you won't have anything or very little to pass on.
And so if you are somebody who had insurance through Medicare, it does not pay for your long-term care. So essentially, you no longer have insurance available. And to be clear, doesn't necessarily mean that you have to be there for the rest of your life. This could be a long-term rehab facility for months, depending on what state you're in and a variety of things. In order to get that care, you have to spend all of your assets despite having insurance, because Medicare doesn't cover this. So you spend all your assets until you're poor, until you're below the poverty line. And then you qualify for Medicaid to kick in to pay for that stay. And if you get out of that state early, if you're able to regain your independence, you no longer have any assets. You had to pay them all down in order to get in there. And so that's what's called the Medicaid spend down. And it's something that people don't know about. And it shocks a lot of people when they're confronted with that, especially family members. And then they find out that they actually have to essentially lose all of their liquidity and assets in order to get that care. This is clearly something that is going to happen to all of us, or it's very common for this to occur. And Medicare is our insurance system for old people. So we should have a better system in place for people as they age.
I don't think you're surprised that aging happens to everybody. Why don't we have a better system in place to prevent this?
Well, I think the Silicon Valley folks are working on curing aging. So as soon as that next anti-aging startup,
Next guest, Brian Johnson.
once Brian Johnson's anti-aging startup comes around, we'll be good to go. This is clearly something that's coming for all of us. And it's pretty surprising that there's such a major structural issue in America.
Yeah, the plan right now is the government's saying, hey, you're not poor enough for us to help you, but here's this one secret that we could give you. Spend all your money and then we will help you.
Yeah.
And, we have a lot of savvy listeners, obviously, to our podcast, maybe thinking, well, what if I just donate all that money before this happens? I can donate all this money to my church. I'll just give this large gift to my grandkids. That doesn't count as spending down. You actually have to be spending the money towards your long-term care. And there's a 5-year look back period. So if they see that you gave $100,000 to your local church, they're going to look at that and they're going to try to get that money back, or say you don't qualify for Medicaid to get this long-term care. So all the loopholes that I'm aware of are closed.
Yeah, they do a pretty rigorous review. And then sometimes you get denied care anyway, and then you're basically stuck. And then it gets really tricky, especially for folks who don't have family members who can support them. They're just kind of adrift. A lot of these people will end up staying in the hospital for weeks to months. There'll be certain teams that are actually, sometimes in some hospitals, have so many patients that don't have anywhere to go to leave the hospital, that they'll kind of dedicate entire teams just for caring for those patients who are basically just living in the hospitals, taking up additional resources. It's a crazy system. I actually don't know what other countries do for this, but I'm sure they do it better than we do.
Yeah, the one country I am aware of is in Germany, and Germany created the first universal long-term care insurance program now about 40 years ago. And everyone pays in as a payroll tax, like we do now for Social Security and Medicaid. And then that will pay for people's long-term care when they get older. And I really think that's the type of program that effective governments should have for their people.
You know me, Washington State guy, always proud of my home state.
You're from Washington? No one knew.
Yeah. We also incorporated a long-term care tax as a payroll tax. So people pay it as a payroll tax, and it helps support these programs. So people do have somewhere to go when they get to a certain age and to certain needs. They're clear models to how to get around this. And they, like anything, involve thought, good policy, and upfront investment.
Yeah, I mean, it's not just Germany. Japan has it. The Netherlands have it as well. The Netherlands is one of the most generous in the world. And again, that's funded by everybody paying in. So in other countries, it's a human right, it's a public responsibility. But the model here in the United States is who can spend their money fastest to get below the poverty line.
It's pretty amazing that people who have worked in our economy for years and years, they're contributing members of society. They've been a part of the fabric of America. And once they get old, fuck them. Who cares about them anymore? Let them get poor and use all their assets, and we're good to go. It's pretty wild.
So let's talk about surprising fact number 2 about the healthcare system in the United States. And that is, does Medicare cover the entire body, or there's certain body parts that are not covered? What do you think? I know you know the answer to this.
Well, I do know at the VA that sometimes they can get penis pumps. I don't know if that's what you're alluding to, but we have plenty of VA patients.
That is covered, actually. But what's not covered is your eyesight, your vision, dental, or hearing. None of those are covered under most health insurance plans, and they're not covered under Medicare.
If you had surgery on your eyes, or if you had surgery on your ears, or if you had surgery on your jaw that affected the teeth, if you had a cancer in there or something like that, all those things would be covered. Those are quote unquote medical issues. When it's a non-MD that is getting the payment, so in this case, it'd be an optometrist for vision and new glasses, an audiologist for getting hearing aids, or obviously a dentist for any of your dental care, those folks aren't covered by this insurance program. I mean, obviously those are important parts of the body, taste-ish, vision, and hearing, kind of three of our main senses that give people meaning and joy in their lives. And they don't get to participate in the general care of those areas. It's pretty wild. It's a reflection of the way we view healthcare in America, that it's not about the whole body. It's not about taking care of every aspect of a person. It's a little bit more directed towards how we can get money out of treating somebody.
You're starting to sound more like RFK by
Yeah,
the
I think we
minute.
should have less dye in our food and maybe just less vaccines.
A patient recently who had a dental abscess, so something that a dentist probably could have taken care of. This individual had no dental insurance, did have health insurance, and then came in with an infection of the heart valve called endocarditis. And this was an infection that spread from the mouth and went to the heart, had to have surgery. This is tens and tens of thousands of dollars for this one person's medical care. When if they would have had routine dental care, they wouldn't have gone through this really traumatic experience that's going to impact their health for the rest of their life. And it would have cost the system less. So it's just very weird how dental care is so intimately linked with a person's health, yet our health insurance does not treat the mouth the same as it does any other body part. And maybe you're right about some of the historical reasons, but it's something that I think needs to change.
Yeah. Make America smile again.
Make America smile again. But I know why, David. I know why we don't cover it. It's when the insurance company sends you that bill, if you can't see, you're not going to be pissed because you don't know how much it is. You can't call them on the phone if you can't hear. And then when you're stressed out, you can't even eat your favorite snacks because your teeth aren't there. So I think this is just big insurance companies billing people and you can't see how much
That was a good tripartite joke, Jake. Did ChatGPT help you structure that one?
Yes, sir.
Okay, on to fact number 3.
One of David's favorite jobs is doing the night shifts, and he is often working 3 consecutive nights in a row because he gets a little bonus after he does 3 nights in a row. But you know who else gets a bonus after 3 nights in a row? It's our patients with Medicaid and Medicare. David, why is that?
Yeah, so 3 nights in a row.
I'm just too funny
no,
today. David thought this was going to be a bone dry, terrible episode, and there he is.
I got a
4 seconds.
Fucking comedian on the line. Jake, don't tell my boss I'm doing 3 nights in a row. But what Jake's alluding to is this concept. It's actually kind of bizarre and in the weeds. When you are admitted to the hospital, you can be admitted in 2 different ways. One of them is a regular admission. You're sick, you get in the hospital, you need care. The other one is what's called under observation status. So you're not technically under regular admission status, you're under observation, where you're not that sick and they're just kind of waiting around until you find out a lab value or you think you're going to get out of the hospital while you're being observed. It's right there in the name. So why does that matter? If you're admitted under observation status within the hospital, you don't qualify for a skilled nursing facility. Even if that's why you go to the hospital, because you can't be taking care of yourself at home, you're waiting admission to a skilled nursing facility. If you don't qualify for an admission for 3 days, a 3-day rule, so you have to be there for 3 midnights, then you don't actually get benefits for when you discharge from the hospital into a skilled rehab facility.
If you're in observation status, that's like you're in a situationship with the hospital. No one's formalized anything. You're just hanging out. It looks the same. You got an IV in your arm. You're getting the same medications. The other people aren't sure what's going on.
Yeah.
But you know what? You're probably getting kicked out the next
Sleeping
day.
in bed.
Sleeping in the same bed. Exactly.
Yeah, it is the same. It's on and chilling on TV while you're doing it.
Yeah. But the interesting thing is observation status is billed under Part B, which is the outpatient portion of the Medicare insurance, as opposed to Part A, which is the inpatient. And you can only get those SNF benefits if you had the inpatient, the Part A billing beforehand. I think the point is, like, why do we have this dumb rule where you have to have a 3-night stay to get rehab services? If you can be out of the hospital in 2 nights, but you still need something extra at this SNF, it makes more sense to get those patients into an area that's cheaper, but instead we're keeping them for an extra day so they qualify for those benefits. That's what's happening in practice.
I guess one of the broader points to take out of all 3 of these is that it's just kind of bizarre about how we think about health insurance and health policy in our country. There's not a unified kind of holistic approach, and attempts to kind of bring that about have largely failed.
And I think the reason that there's this 3-night rule is because we don't pay for long-term care in this country. They didn't want it to be a loophole that you could like do 1 day in observation and then get to this custodial care in a SNF and get around them banning long-term care. So those 2 are based in the same principle, no long-term care. But I agree with you, David. These are just kind of very bizarre and often archaic rules, and we need to modernize our insurance here in the United States. I mean, it's from 1965. So here's the thing. This was created in 1965, this rule about the 3-night stay. Modern medicine, we are so much better than we were in 1965. We're helping patients get better faster. They're getting ready for discharge faster. And we need to update that rule because it's a leftover from the LBJ era.
Well, the broader point that is important to continue to hammer on is that right now we have a system that is not working for a lot of people. And it is just shocking how many people fall through the cracks and how frequently their healthcare needs end up contributing, not necessarily the health issue, not the medical issue, but the broader healthcare needs and the system end up really detracting from their quality of life. Even if they can get past the medical problem that they're faced with, if the doctors can heal them or whatever, the system fails them and it doesn't allow them to actually thrive or to go off peacefully and contentedly into the night as they age. I mean, I think that is the point that we really want to hammer home, is that this isn't about a failure of medicine. This is about a failure of a medical system. And that's really something that we need to continue to address in America.
The politics of the next 3 years is going to be centered around affordability for Americans. And these 3 rules that we talked about, while in isolation may seem small, go at this larger concept that the current system we're living in is not affordable for Americans. One health crisis when you're older and you need to go into long-term care totally wipes out the decades of your work. So we need to focus on a system that is affordable for everybody.
To that affordability point, Jake, if we think about our second issue that we touched on, the lack of vision, dental, and hearing insurance or coverage under Medicare is shocking. I mean, these are extra costs that people incur just to be able to see, just to be able to hear with hearing aids as they age, just to be able to have teeth that work. I mean, you can't afford teeth that work in this country. Like, what? How does that happen? It's just shocking that there's so much baked into this affordability question that we are not addressing as a country, or we're just kind of dangling out of reach for people. And it's totally unnecessary. This is a choice that we are making as a country.
As we're recording this, largest audience is actually people on Medicare. And I worry they're not going to be able to hear us because they don't have hearing aids.
They definitely won't be able to see us on the screen. I mean, if nothing else, Medicare, get it together for the podcasters of the world.
Yeah.
Podcasters need you.
Podcasters are people too.
All right, Jake, so what do you think? Is this healthy policy, unhealthy policy? What are we talking here?
As far as unhealthy policy goes that we've spoken about in this podcast, it's not the most unhealthy thing that we've heard of. Children aren't dying. Millions of people living with HIV aren't stopping their medications. But it gets to this central question that living in America is no longer affordable. And these 3 policy pieces are definitely unhealthy. We should ensure everybody has long-term care. We should ensure that everybody can get to a rehab facility and not have to stay in the hospital longer than they need to. And people should be able to see and hear. So I think we need to change the system and make it more healthy for everybody.
Yeah, I agree. This is more of like loopholes and people falling through the cracks rather than a systemic chasm that swallows up lives. But it really does change the way that people approach their end of life. And it really, absolutely, I mean, the insurance on hearing, vision, and dental care absolutely changes the way that people experience their day-to-day world. And I think we need to address that in a way that gives everybody the same opportunities that the wealthy have. Or not even just the wealthy, other countries that are at our same economic levels. Like people in the same socioeconomic class in different countries don't have these same failures that Americans have. And I think that's just something we can learn from.
Free glasses for all.
Free glasses for all.
Until next time, that was the Unhealthy Policy Podcast.
Yep.